everybody. Welcome back to Psychedelics Today. I'm joined by Dr. Marques. And before we dig in, just everybody, if you want to support us, you could leave a small monthly donation over at Patreon, patreon.com/psychedelics today, or check out some of our classes at psychedeliciceducationcenter.com or psychedelicstoday.com. I think that's it for now. Yeah. Or leave us a review on iTunes, Facebook, or something like that. We'd love it. All right, let's dig in. Dr. Marques, you are running a pretty interesting ketamine business in Florida, Pasithea Therapeutics. Did I pronounce it right?
Yes, that's correct. We are based in Florida. That's our headquarters because we have a Pasithea Therapeutics is a new company, and we have a two-pronged business model. One side of our business is developing new drugs for the treatment of psychiatric and neurological disorder. But we felt a duty to offer some relief to patients who need some immediate relief in these symptoms, and ketamine seems to be a drug that is being used off-label still, but with tremendous success. And we're going we aim to be a company delivering ketamine in all US, mainly at home ketamine infusions. And we
In-home
start
ketamine infusions?
at home, yes.
Ooh,
So an anesthesiologist will go to your house to deliver ketamine with a nurse, and you have ketamine infusions in the comfort of your home under a medical supervised professional.
right. Yeah, that's beautiful. I've maybe heard of people suggesting in-home work, but I've not seen anybody actually pull it off. And
Yes,
that's really great.
we're pulling it off in initially New York State and California, and then we aiming to continue to do this business across the US as we gain some comfort and some exposure. We already planning to roll in other states, including Florida, of course.
Yeah, that's beautiful. So I guess let's talk about you before we dig too deeply into the business. So you born and raised Portugal, and you luckily stumbled into Imperial and King's College in London. So you
Yes,
got to hang out with all these really amazing people.
exactly. So I'm a psychiatrist by training. So I've graduated in medicine in Portugal. But I realized that for what I want to do, mainly research, I needed to leave Portugal at least for a while. I came to US. I worked in my clinic for a while. Then I went to London because there's where the largest center for psychiatric research in Europe, and together with Harvard, they are running back to back on who's the best in terms of the publications and the quality of your research. So I've done there my PhD, basically looking to using imaging to try to understand how the brain works, and then I continue after my PhD to do work using imaging as a biomarker for treatment response in multiple psychiatric disorders, and then develop a taste for psychopharmacology, how you could understand which are the receptors or enzymes in the brain that you should target as novel treatments. Also working a lot on repurposing of drugs, using drugs that are used for the treatment of other disorders and repurpose them for psychiatric disorders. We run multiple studies, monoclonal antibodies for the treatment of schizophrenia, riluzole, and so on, while also understanding the role of certain brain receptors using PET imaging, that is molecular imaging, using a small radionuclide to light up those receptors, and trying to understand what is wrong in the brain of patients suffering of certain psychiatric disorders. So that's gave me a broad scope on what's wrong in the neurobiology of illness, and how we could target them more effectively. Of course, and then I worked and I still have a position both at King's and Imperial College. And this is where the cutting edge research is being done into world together with US. And the most important thing is that we don't look to molecular entities, compounds, as drugs or pharmacological agents. Anything that change your brain or that act in a receptor in your brain and change it, that can be considered pharmacological manipulation of your brain. And of course, some of these compounds have been used recreationally, but the majority of compounds, they actually come from the pharma industry. MDMA was synthesized by Merck, LSD was also synthesized by pharmaceutical companies, and so everything is actually a drug, a pharmacological agent, and then there's been some misuse of this substance. And I can mention the case of opioids. Opioids are fantastic drugs for the treatment of pain disorder. They are the strongest analgesic that exists, but unfortunately they can be misused, and that happens repeatedly in medicine. But the way I looked to molecular entities, I look to them from a very agnostic point of view. I just want to understand: are they targeting the correct brain receptors for the treatment of a particular condition? Yes or no? Does this make sense? Are we correcting something? And that led me and many other brain researchers, neuroscientists, doctors to just try to help patients. Whatever we need to do to help suffering, that's our primary goal. And then we just need to use this substance wisely.
Right. Agreed. There's a lot less wisdom out there than I'd prefer around drug use and in recreational and medical settings. Right. It's
Yeah, completely. But what you've seen in this recent in this revolution that is happening in psychiatry is all of this renaissance of substance that we consider them as bad, toxic, and we're actually using them again. We have laughing gas for treatment-resistant depression. You have MDMA for PTSD. You have ketamine for treatment-resistant depression, PTSD, psilocybin. We've been rediscovering uh, these drugs that we thought they were lost for the dark side, and we are just using them again. And this has been a tremendous and fantastic revolution on the treatment of psychiatric disorders, for which we actually don't have nothing coming up. And it's been a desert on new drugs in the past 20 years. And it's not, we cannot blame pharma companies. They've done fantastic work. We cannot blame neuroscientists. Everyone is trying to solve them, but the brain is so complex. The brain is so far away from any other organ that we have 100 billion neurons, 1 trillion synapses, that trying to understand what's wrong and how to correct it is really, really hard. And we've seen that, for example, you just to, to biggest advance in medicine, they need years of research before you come out with a drug. For example, HIV, we're talking about a virus, is minimal. They have a couple of microns in size, and we spend like 15 years, 20 years studying it before we started to come out with some drugs. And now, if you have HIV, you're not going to die of it. It's moving to being a chronic disorder, and hopefully we're going to solve it. The brain, it's so much more complex than a simple virus, that we need to build on the foundations of research, of the understanding how the brain works, and then when the drugs start to come out, there will be hopefully another evolution. Until that moment, we need to use what we have and try to improve patients' life, because that's the most important, is help people who are suffering currently. And if it is with psychedelics or ketamine, let it be, as far as we do it safely and as far as we do it wisely.
So one of the biggest things around ketamine that I love is how affordable it is relative to other medications. It's not always really cheap to deliver, but it can be in some cases. Though optimally, I think consensus right now is that infusions are most effective for a lot of psychiatric indications, but that's also the most expensive, right, relative to a lozenge or a simple injection in the shoulder. Do you have any thoughts on that idea of
Yeah, it's
efficacy versus route?
yeah, it's definitely it's not to drug that is expensive. It's actually to delivery method, and the need to have to do it in a supervised setting with a professional supervising the infusion and managing any transient side effect that may come up. You've seen also recently molecules that are very similar to ketamine, for example, esketamine, that's a drug called Spravato developed by Johnson and Johnson that is given intranasally, but they're still expensive because you need to pay for the cost of research and the trials and so on. So it end up not coming so affordably, such as a ketamine infusion. But every time that you look to the cost of a drug, you need to do what people call a pharmacoeconomical analysis, because one thing is to give 6 infusions that can cost you a lot during that period. But then if you enter remission, and if you're going to be symptom free, and if you're going to start working again and start to produce, and in the end, if you calculate all of these costs and you're not going to pay for your medication for the next 6 months or 1 year, then the drugs become much more cheap, or in an economical analysis much more affordable. So we always need to calculate not only the costs of giving the drug on that particular period, but also on the gains that you're going to have into future. And on that sense, it's definitely from a cost effectiveness analysis, it's a drug that is actually end up being cheap. And of course, there's now a wide range according from where it is giving, office, at home, different states with different prices. There's a lot of competition in this market as well, but I wouldn't say that this is a very pricely cost for the benefits that it has.
Absolutely. Yeah. I've only had the pleasure of using it once outside the context of orthopedic surgery. And it was
Mm,
pretty interesting. Yeah, an intramuscular injection. It was um, fascinating. I um, probably wasn't suffering in the right way for me to notice a huge benefit.
yeah.
But it was, still really interesting. It, it's kind of like a psychedelic inverse, like not as much content, but still like really fascinating.
Yeah, it is. It's intramuscular is always a challenge, because you're giving into muscle. You never know how long it will last, and this transition from the drug to the muscle to the bloodstream and reaching the brain is harder. That's why using an IV is much easier, because you can calculate immediately how much goes in, so how much reach the brain. If the patient is experiencing any side effect, you can stop it immediately, so you can balance it much better. In terms of side effects, and this is the difference between recreational ketamine and medical ketamine, is that you're not with medical ketamine, the doses that you are giving, it's much lower than the doses that you're giving in the context of recreational use. That's why also a lot of people concerned about, oh, if I'm going to receive ketamine, may I be will be like a will I start liking the effect and start using the recreational? That's a big concern. But actually, with to those that were using it for the treatment of psychiatric disorder, we're using much lower dose, so patients feel much less that hype. So there's no cases of patients after receiving ketamine start using ketamine recreationally. And the side effect, as you said, is a bit like a psychedelics inverted, because there's a couple of similarities with psychedelics. There's eventually some uh, loss of the sense of time and space, but the majority of slowdown experience. But the side effect that is most reported is the dissociation, is to feel, or it's not an out of body experience, but it's a feeling that you are not in control of yourself, that something is changing, that you lose a bit the sense of your own body. That lasts couple
Hmm.
of minutes, and then as soon as you stop the infusion, that will typically go away, and the patient just continue their life. But it's for those who have tried, it's for some people it's frightening, people who love to be in control and they don't like to lose it, but the same is applied to psychedelics and to some other drugs.
So, from what I understand, there's been some research done on IV infusion DMT, some at Imperial. There's some other projects going on. And from what I understand, you need to actually adjust the infusion rate here and there to keep a good, consistent concentration in the blood. Is that similar with ketamine? Is it Is
Yes,
there?
yes. So the typical ketamine infusion is zero point 0.5 milligrams per kilogram. That's the dose you adjust by the body weight, and then you use normally a way to give to spread out this dose across a period of time, but in a way that the patient receive constantly the same dose. There's an infuser that do that for you, so there's no one pressing the needle. There's a machine that is making it a constant infusion, so that your ketamine levels reach constantly the same concentration in your bloodstream and in your brain. Of course, there's as you infuse, there's uh, and as the drug increase the concentration in your bloodstream, it will go high and then it will reach a steady state. With any other type of infusion, and that's the case now with DMT that is also being given by infusion, you use the same method to calculate. You don't do that during the infusion, because it's normally you don't have the time to do it. You do it that pre-infusion, and the only thing that you can typically change is if the patient is really not feeling well, or feeling in some way too strange. You can immediately stop the infusion or reduce the infusion, so for the benefit of the experience.
I love that. And can you actually blend in something like Zofran into the infusion to minimize any kind of risk of nausea? Or
You can, you can. Normally, you don't need to give it with infusion. You can give it orally, because it's well absorbed, and the patient just take a pill before. If you know from the past experience that the patient feel a lot of nausea, you can try to give something before the next infusion to minimize that. So we tend not to give anything. So the typical side effects that you see that are not psychiatric related or psychologically related is definitely nausea that can happen, and some patients eventually end up vomiting. Very few, but nausea and some tachycardia, your heart racing, your blood pressure getting high. It's impossible to predict those who are going to experience that or not. It's always a small percentage. But what you can do, because typical treatment is done on a cycle of 6 infusion, is on the next time you know that this patient is predisposed to have this type of side effects, you try to minimize by giving some anti-nausea pill or having immediately access to a drug that reduce your blood pressure, and give it as soon as the blood pressure start to increase, or your heart racing, or give something just to control your heart rate. So, and again, I must say that at this moment, the majority of patients, the large majority, above 90% of patients, don't experience any type of side effects.
I experienced zero,
Yeah,
zero nausea. Zero anxiety through the whole thing, which is unparalleled. Like any drug, I'm typically having a little bit of anxiety. Ketamine, for whatever reason, it's like,
everyone that experiences a new substance, any drug, you can take any drug for any conditions in medicine, that before taking it you're going to feel anxious. So that's the starting point. From anything that you never tried before, you feel a bit anxious. So we need to we acknowledge that already, and that's our team is there to reassure the patient that everything is going to be fine. But we spend a lot of time training our staff to manage some side effects, but in the end, no one experienced nothing, and they almost complain, well, this we haven't seen nothing. Is And there's a lot of people have this view that if I don't experience any side effect, maybe the drug is not doing nothing. We have almost that view that maybe just enter my blood and left without reaching the brain, or maybe I just took this pill and it just left without ever being absorbed. But that's it. We see a lot of patients who just take it and they just continue their normal life minutes after the infusion stop.
yeah, I was sober enough to be able to do plenty of normal stuff, everything but driving. I was pretty
Exactly.
cool with.
So
Yeah,
we give some instructions to patients. Do not drive, do not take any decisions, sign documents, do not do any type of work that needs any cognitive demands, do not operate machines. We give all of those recommendations just in case. So we like, and the beauty of doing it at home is that you don't need to be to drive home, or you just there. You can rest, you can sleep, you can watch a movie, and some hours after you can resume your, or the next day you can resume your life.
yeah, absolutely. Um, so you had a mention on your website about treating fatigue for multiple sclerosis. Was that right?
No, that's not. We never. That's not on our website. But once we're going to operate initially only for treatment resistant depression. There's a couple of studies that are mentioning and supporting ketamine for the treatment of PTSD, and definitely that's a field where we would like to enter, because at the moment there's no drugs. There's only two FDA approved drugs for the treatment of PTSD, and they both do the same thing. They are SSRIs. So there's a huge need for treatments in that space. And then you see a lot of reports, small clinical trials showing that ketamine is effective for a wide range of disorders, mostly in this phenotypically related space, meaning disorders that share some symptoms with depression and PTSD. So, all of the anxiety disorders, such as generalized anxiety disorder, OCD, and so on. So, anorexia, even substance use. You see a lot of uh, um, trials here, but you know, you cannot. Uh, uh, you cannot show efficacy based on a single trial. You need more repeated studies coming out so that you can start giving it with more confidence. So in medicine, that's how medicine operates. You cannot just trust one thing, not because you distrust the researchers, but because sometimes that's what's happened. There's placebo effects. That's for some reason to drugs show efficacy, but in the end, with multiple studies, the results are head to head with placebo. So there's no the efficacy is not higher when compared to placebo, and we're waiting for those trials to come out, and then we will be happy to use it for other disorders.
That's really great. And how are you approaching this whole idea of new drug development? Wildly expensive program, right?
Yes. So that's the problem, because even synthesizing a new, even creating the compound, the molecular entity, there's teams of medicinal chemistry people with backgrounds in chemics that are just used to manipulate organic molecules to try to create a drug that binds to a specific target that you given it to these people. So this is definitely time consuming and very expensive. So on the process, and that's what we aim to do. We raise money for that, um, always with the notion that there's a large unmet need for the treatment of these disorders. If you look across the spectrum, the majority of disorders are rising in the field of psychiatry, um, and that's due to environmental conditions, now COVID, but we see an exponential rise in psychiatric diagnosis, and we see that a large majority of patients, either they do not receive treatment, in this case, drug treatment, pharmacological treatment, or if they receive it, they experience side effects, or they don't like, or they don't show, or these treatments don't show efficacy. So we need to come up with new drugs, and we believe that there's still a lot of potential, and as neuroscience evolves, new treatment targets come up, and we aim to develop drugs for the treatment of these conditions. If we're going to get there or not is, of course, a big question mark. The failure rate is very high for psychiatric drugs, is like around 93%. For medicine in general is like 90%, meaning that 90% of the drugs that are tried, they end up failing. So it's definitely a high risk and a high reward as well, business. But I think we own this to patient community, for everyone that is suffering.
Well, I'm glad you're working on it. Are you? I've talked to a number of folks linking up with AI and all sorts of really interesting computer modeling. Are you looking at that kind of stuff at all?
Yeah, the companies uh, that you work with, these teams of medicinal chemistry, what they typically do, they run through libraries of millions of compound, trying to that each one of them just change a single atom of carbon or whatever, or hydrogen or fluor or whatever. And in this screening process, this is very time consuming. So that's where AI plays a role. They can immediately find compounds that bind to those targets. They can do this match much faster. So everyone is applying AI to this process of finding uh, compounds faster. So, and that's help a lot to the pharma industry to come out with drugs faster and cheaper, um, and that's two ways. So we definitely uh, working or collaborating with these teams that are using AI tools.
Right. That's it's a really interesting prospect for sure. Um, all right, we're coming out of COVID, um, and we're going to see a probably, you probably already are. I thankfully don't work in a hospital, so I don't have to see it, but a huge spike in depression, PTSD, trauma from all of this really crazy stuff we just went through with the pandemic. Are you seeing are you seeing any of that already, or how do you think ketamine might be able to help?
Uh, for patients, so it's a great question because to these frontline workers, they've been exposed to a long period of stress and trauma. You know, direct, indirect trauma for seeing others dying in front of them without them being able to help them, and young people, and it's and people getting admitted to ICUs and so on, but also some direct exposure. You see, you are yourself into frontline, and you can be contaminated at any point. We knew from previous pandemics, um, SARS in Hong Kong and so on. We know that frontline workers experience symptoms of PTSD in 2 years after this pandemic. So people were expecting that. The studies have just recently started to come out. Initially, a couple of studies from China, some studies in Europe and US. There's a wide range of PTSD symptoms in these frontline workers, ranging from 3% to 70%. And of course, it depends on, I don't think that any frontline worker at this moment is going to
Mm,
suffer from a PTSD, because they have PPEs, they know how to virus spread, they know they have support, they work in shifts, they don't work too many hours. But if you put yourself 10 months ago, you're working, you didn't even know how to virus spread. You need to quarantine in an hotel or in a room because your family didn't allow you to come home. You work with bad PPEs, and that's raised a lot of that was a trauma experience. And so we're starting to see it. I haven't seen one yet. I've seen some depression, some stress, but not a formal diagnosis of PTSD. But they will start to show up. That's for sure. Studies are reporting it. So uh, uh, it's and collectively, as a society, this has been, trauma can be understood from an individualist perspective, but also as a society trauma. You can conceptualize uh, uh, everything from a societal point of view. Think about Vietnam War. It was
hmm
a trauma for those who were there, but it was a collective trauma as well. And we're just trying to come to peace with it. We are now into celebration phase, things opening up, people partying
Yep.
again. But there will be a time that we also need to do our healing as a society. That's why
hmm
you have celebrations or murals or anything that allow the society to heal and talk about it, because all of the therapies for trauma is about either exposure, remembering to trauma, and come to peace with it. Collectively, we are going to do that in the coming months for sure. Uh, from an individual point of view, it's going to be hard. I see ketamine as a way forward,
hmm
as a potential treatment for some of these patients. Uh, as I said before, there's nothing that we can offer to these patients. There's a lot of good psychotherapy, trauma-based psychotherapy, there's CBT, there's other type of therapies, but it's also not for all. Some patients don't like to talk about, and it's in the beginning talking about to trauma is not easy. That leads to patients dropping out of treatment. Pharmacologically, you only have these drugs, these SSRIs, and that's you end up seeing a lot of off-label use of other medications. You see people using antipsychotics, mood stabilizers, other antidepressants. So typically, patients polymedicated. Polypharmacy is common in
Hmm.
this treatment, and I see ketamine as a treatment for some of these patients who are not responding to the first line treatment. It's not an universal panacea. We're not going to cure all of the patients. The biggest study so far has been published recently in a very prestigious psychiatric journal, that's the American Journal of Psychiatry. And what they show, and they gave 6 infusions of ketamine, and other group of patients receive midazolam. So we're trying to minimize the placebo effect so that the patient didn't feel some dissociation, think, oh, I took something, I took ketamine for sure. With this drug midazolam, you also feel weird or something like that. You think, oh, maybe I received ketamine. And what we saw in this study is that almost 70% of patients responded to ketamine. When I say responded, doesn't mean that the patient entered remission. And there's
Hmm.
something that people need to understand. There's a difference between responding, that's symptom reduction, and remission, that is absence of symptoms. So this patient responded, meaning that their symptoms subdue, reduced,
Hmm.
they're feeling better. Maybe they still feel some symptoms, but they're overall feeling better. So up to and 20% responding in the placebo group. That's a huge difference between almost 70% and 20%. So the drug definitely show up a remarkable efficacy for the treatment of symptoms in these patients. Of course,
Hmm.
there's always a problem with ketamine. Some of these patients end up relapsing after a period of approximately 1 month. But if you meet someone who is experienced PTSD symptoms, even 1 month of relief of symptoms is tremendously helpful. They make them live again. So
Right.
we'll see a space for ketamine into treatment of PTSD for sure. And let's hope that the medical community embrace this.
What are the biggest groups doing this research right now, or most interesting groups doing the research? Maybe that's better.
Um, so it will depend on to typically research groups are more divided into conditions they treat rather on the drug they use. So you see research groups studying schizophrenia using multiple drugs, research groups studying PTSD using multiple drugs. The only place where it's not the case is in psychedelics, that those who are dedicated to psychedelics, they like to use psychedelics for multiple conditions. So it varies between the majority of groups. They've been using ketamine for treatment resistant depression, and you see John Hopkins, Yale, Harvard using it for PTSD. There's other groups. So there's not a single group uh, pushing it, which is good, which means that there's a wide acceptance and wide interest in this drug.
Right, that is helpful. Um, so yeah, I'm really hopeful for the future of this drug being included more. I just heard about some clinics offering ketamine for psychiatric interventions covered by Medicare, which I think is a really big development.
Yeah,
Um,
there's it's a problem of all of drugs that we've been using off label in medicine, and people need to understand that it's not because it's not FDA approved, that is not good. All of this repurposing of drugs means that you pick up a drug that has been into market for years, they lost its patent, and then you're trying it in other disorder. But to get FDA approved for that disorder, you need to conduct to this, and now everyone with COVID, everyone knows about it, but you need to run this large scale called um, phase 3 trials involving hundreds or thousands of patients. They are very expensive to conduct. Typically, pharmaceutical companies have an incentive to spend all of this money because they know their IP, their patent is going to allow them to use this drug exclusively for a number of years where you can recover that money. Once you lose the patent, there's no incentive to do this. So the drug ends up in this limbo that you don't have these studies to submit to FDA and get approved, and all the trials, but a lot of trials showing efficacy that are small trials. And that's the problem of ketamine. Ketamine has been approved by the FDA in 1970 as an anesthetic, and only recently, in the past 15 to 20 years, have been repurposed for the treatment of psychiatric disorders. That's insurance companies um, start to pay interest to this. It's really helpful, and that's something that is showing that everyone is pushing this in the right way.
So for this future with like we see MAPS and other groups are going to be able to bring their products to market pretty soon, within probably 2 years or less, is my guess.
Mhm.
Um, do you see any kind of room for your company to include that kind of work, or do you have any plans for tryptamines or MDMA?
No, to when you're doing, you need to be clear from a biotech perspective where you want to act. Both me and our chairman, Professor Larry Steinman, who is a neurologist, our main interest is in the intersection between the immune system and psychiatric and neurological disorder. That's
Oh,
where
very
we
cool.
conducted a large piece of our research, and also this interaction between psychiatry and neurology. And our drugs are mainly going to be targeting uh, that space. The problem, and it's not that I'm a strong believer on the role of psychedelics for the treatment of psychiatric conditions, but it's also now an overcrowded space. You see a lot of companies already well advanced in their research, in their studies, and there's no point for you to start so behind. So we will let the current companies to run this race, and hopefully they'll come up with new drugs. What you see a lot on this space is the reformulation of drugs so that you can get a patent. The same thing as Johnson and Johnson has done for with S-ketamine. You see companies developing norketamine. You see companies develop ways to deliver ketamine orally, intramuscularly, in other ways, so that you can get a patent, so that you can get an edge. Uh, our drugs, the ones that we aim to develop, are going to hopefully target uh, other brain targets than to ones targets by psychedelics, that is 5-HT2A, a serotonergic receptor. So we're not going to be there. So we're here for the long run. We're here for something that will last for years.
Right. I like that. Um, it's yes, it's just a really interesting market trend to watch these groups kind of set things up provisionally for ketamine, as if they're just going to stop it at a certain point. And it seems a little goofy to me because it's a proven drug, in my opinion, for a lot of things. And um, why would we just throw it out? and it's, safer and a
Yeah,
lot less scary than a lot of the other big
yeah,
ones.
yeah. You know, efficacy is something that you need to be very careful on when to use it. And the big problem here is that you don't want to create false hopes. Medicine is full of drugs that end up being false hopes. And as a medical professional, I need always to warn patients that uh, you need to be clear and sincere and honest with what you're saying to your patients. You cannot inflate results. You cannot say things that are not proven. And we know that to show efficacy and proven efficacy, you need these large trials. So until that moment, you need to be, and the same thing with psychedelics. We're waiting for the results and many other drugs. There's a huge opportunity uh, and a large number of small trials that has shown results. Of course, it's up to the patient to also be informed and decide if he wants to do it or not. So I'm just counterbalancing this hope that all patients have with some reality, and the same thing will apply to psychedelics. It's not going to be for all. Some patients are not going to respond. Some patients are going to respond partially, and some patients are going to have a tremendous experience and going to be life changing. So I think the next couple of years, and as more research is coming out, the picture will become clear and clear. So we hope that the next wave of research in this space will give us a better understanding for the position and the role of this drug.
So that's a really great point. Brings up two things for me. So how do we want to attack this? So first off, groups like the VA here in the States. I was just chatting earlier with somebody who works there, and they had some leading PTSD experts come and start talking about the prospect for MDMA assisted psychotherapy
Yeah.
to the employees at the VA.
Hmm.
During PTSD month, as I think, is it this month or last month?
Last month.
Last month. So um, nobody was willing to actually even discuss it with this person I was just on the phone with. And I wonder if there's some sort of fear based on MDMA being a controlled substance, and that limiting what people are willing to discuss, even in terms of active clinical research. Um, does that seem like an accurate kind of supposition?
Well, I know that VA, of course, is and needs to be very careful on things that they propose, and uh, this MDMA assisted psychotherapy is even a more interesting story, because in the end, if you give MDMA alone, you don't see efficacy for the treatment of PTSD. So MDMA is needs to be combined with the psychotherapy. So it's a form of facilitator uh, to psychotherapy, which make a very interesting combo. You don't see this happening in any other disorder in psychiatry, that a drug is approved together with a psychotherapy and not as a standalone. The results of the recent studies are very supportive and very exciting. But again, we're talking about a small study and limited. So I understand that we need to have. Furthermore, of course, it's a controlled substance. You have problems associated with its use and deployment. And I see and I understand how careful you need to be when you pass a message that the VA is already using it or it's already widespread and so on. So you need to be careful before making that type of movement. But they are also quite aware of the needs of new drugs. It's not that they've been pushing a lot for better, innovative, novel approaches for PTSD, and unfortunately, it's not something that is all of there's very few drugs on trials, novel drugs on trials for PTSD. So you need to have a lot of support from to research from academia and pharma to move and develop new drugs for PTSD.
That makes a lot of sense. Um, and now the next part being, what do we do with all of this historical data? I know we've had decades of research before data was collected in as tight a fashion as it is today. And a lot of us in the psychedelic movement see it as a sort of travesty that there's no way to really translate that legacy
Yeah,
data into what we're doing right now. So we're having to spend substantially more money than we might be able to otherwise.
yeah.
Any thoughts or perspectives on this?
Well, unfortunately, the way we conduct research now and the way we conducted research before is very different. So nowadays, it's all about the study design and how well you control for certain confounders, how well did you compare groups, how well you design your study. Unfortunately, there's a lot of data that has been acquired in a way that you could not use it nowadays for nowadays research. You cannot forget that there's people out there in the past that have tried things, and there's reports and so on that any research that is reading them should read them in a way that at least increase their uh, the curiosity for why 50 years ago someone tried this and experienced this. That's a bit how psychedelics were rediscovered, because there were all these trials in the 70s that were completely forgotten until someone read them again and saw that they've been used and they show efficacy. So the way I see the old data that were collected is in a way that you those who read it make use of it from a science perspective, as a way to increase your curiosity and as a way to trying to reproduce those findings. So maybe a lot of research is just redoing it again, using new methods, new drugs, new delivery uh, ways, using brain imaging as a biomarker of response and trying to improve our knowledge, just trying not only replicating but also adding something up.
Yeah, I can see that. Um, cool. So we're at about 7 minutes left, and I don't know that we covered everything about your business that we should. What in particular, if anything, do we miss?
In terms of business, we cover with just starting up, and we're just starting to roll both uh, sides of the business. And I think the most important thing for everyone who's listening to us is first is this vote of confidence that uh, there's a lot of companies trying to come up with new drugs, and for everyone that is suffering nowadays with a mental condition, that there will be new treatments coming up in the coming years. So uh, keep your hope, keep your hopes high, and just wait and let these companies do their work, and let the academia also come up with new ways to understand conditions. The other thing is really also to raise awareness. I keep on seeing and keep on trying to push to raising awareness that we're seeing an epidemic of mental disorders. We're seeing that the rates of mental conditions are constantly going higher. We need, of course, some change, trying to understand what environmental factors are increasing this. Of course, COVID is such a blip in our lives that no one expected and it happened. But multiple ways that our society is organized are pushing and contributing to the rise in mental conditions. So we need also to have a policy approach to this, and we need to try to changing locally but also nationally, and trying to improve people's life by reconstructing the way the society is organized. You see already a lot of um, ways that we're reducing it. There's a lot, if you go to a school, a lot of bullying prevention, but at the same time you see the rise of online shaming and insulting and so on. So, and this, for any kid who is more online than he is offline, how can this be detrimental for their own mental state? But I like to raise awareness. This is not because someone is weak or someone is fragile. It can happen to anyone, and I love to see people coming out and talking about their problems. Anyone, either is influential, rich, poor, but you need to talk to your friends, your neighbors, your family, but definitely raise awareness. And then the other thing is that there's multiple ways to treat mental health disorders. Sometimes even simply talking to a friend, to a parent, it's already very helpful. Sometimes a therapist, they do such a good job. They are so well trained, and they really know how to give support and treatment. And I always, and then the last factor that I always like to talk about is how can you also improve your own mental health. I see people always going to the gym and running, but try also to improve your mental health. Learn to meditate, learn about mindfulness, do exercise. Physical exercise is fantastic to your brain. Release endorphins, reduce your stress levels, improve your self-esteem. So many benefits, and improve your eating habits. There's a huge interaction between what you eat, your microbiome, and your mental state. But and sleep well, sleep 7 hours. This 21st century idea that short sleepers are the best and we should sleep 3 or 4 hours a day, it's completely wrong. So have a good night of sleep, have routines, and so help yourself as well. Contribute to your own mental illness. Do not take drugs. Don't smoke. And I think if we all combine this, we're going to see an improvement in the mental health of society as a whole. We cannot only rely on drugs. We need to rely on a common effort to improve people's life.
Absolutely. Yeah. I remember reading about the comparative study. I think it was the SSRIs and exercise.
Yeah,
So it was like SSRIs, exercise, and SSRIs and exercise. And like, why
yeah,
wouldn't you exercise?
exactly.
Yeah, it's a fascinating situation we're living in. We're kind of, you living in Miami, you can see how little people are sleeping in Miami. Um, Probably similar in New York. I imagine
Yeah,
it's possibly similar in London. I don't know.
yeah,
Um,
it
but
is the
it's,
same. Big cities life.
yeah, when I was living closer to cities, I got a lot less sleep. And now I'm living hour plus away from a city. So
Yeah,
I'm sleeping like nine
that's
hours and I feel great.
fantastic.
Um,
Background
yeah,
noise, light exposure, everything. It's so bad to sleep.
Right. So, people want these psychedelics for a quick fix, and
Yeah,
they can be good for a quick fix, but not necessarily very durable if these other factors aren't in play. And
exactly.
we really need to be looking at that. Um, cool. Um, well, Dr. Marquez, I really appreciate you being here. That's about the time we got, but let's give out, your website, and anywhere people can find you.
So we're going to be at www.pasitheaclinics.com, and that's our clinical site, and our corporate site is pasithea.com. And we're going to be live in the next week or two, so we're just finalizing the steps to be up and running.
That's outstanding. And where will the locations be again? Your main offices and like the service areas?
Yeah, the corporate site is in Miami.
Great. And you'll be able to offer like what, plus 100 miles or something, or plus 20, or?
So we're going to operate nationally. So in terms of
Oh, great.
our ketamine service, because it's at home, we're going to operate from all over to in New York, in Manhattan, starting Manhattan, in LA, LA City, and then we're going to expand throughout the country. As we don't have a clinic-based model, we're going to have an at-home model.
It's amazing. Yeah, I really love it.
Yeah, thanks.
All right. Well, Dr. Marquez, until next time, I really hope we can
Okay.
connect again and learn more about how you're progressing.
Fantastic. It was a pleasure.